Can you see that?
Great.
You can still see that now?
Yep. Audit.
Sorry, I'm not sure what happened then, but I'll carry on. So my interest in audit is partly because I'm now chair of the steering group for the National Ophthalmology Database Audit, which I'm about to describe. Now, medical audit actually goes back a long way. Apparently, King Hammurabi, the sixth king of Babylon, instigated this concept for clinicians by instructing them to measure their care against agreed standards. And amongst the many laws written on the Code of Hammurabi is Law 215, which basically says, if you as a physician heals the person's eye, you will be rewarded with 10 shekels of silver. However, Law 218 says that if you blind the person's eye, they will cut off your hand. So probably a bit more punishment than we would like to mete out these days in the NHS. Now, it's interesting to listen to Harry's talk because it is a reflection of how we work in the United Kingdom in the NHS. And despite the fact the NHS started in 1948, it took a long time for the concept of audit to really work its way through. And it took a certain number of adverse events, including high rates of complications of cardiac surgery in Bristol, for people to start saying, it is not good enough for you to believe you can do something well, you have to prove it. And in a white paper that was presented to Parliament in 1989, the concept of audit in the NHS was introduced, but it still took to 1997 in another white paper, the new NHS, where clinical governance, the need to monitor and appropriately manage the health service and your clinical responsibility, and the concept of clinical audit, the key mechanism by which healthcare professionals measure the quality of care, was really laid out. And alongside it, they established NICE, the National Institute of Clinical Excellence, as it was called at that time. So I'm sure many of us are familiar with the concept of a medical audit. It was defined by NICE and the Commission for Health Improvement in 2002 by that definition, a quality improvement process that seeks to improve patient care and outcomes through a systematic review of care against explicit criteria and the implementation of change. So the concept of an audit cycle, as you can see there, is well established in the United Kingdom and increasingly well implemented. But one of the key issues about audits is what standard? Who should you compare yourself with? And in the past, there was a tendency to compare yourself with yourself and saying, yes, I'm still doing as well as I did last year. Perhaps more usefully, you could compare yourself with other people in your department. And that may make you realize you're not quite as good as you thought. But unfortunately, there may well be inherent systemic problems within that department that limits your full understanding of whether your department and you are as good as you think you should be. So ultimately, perhaps the best way of comparing yourself is against your whole peer group on a national basis. And this is the aim of the pioneers. Rob Johnson unfortunately passed away, John Sparrow and others, back in 2005, who, for the first time using electronic databases, was able to pull data in this first paper from 162 surgeons from 8 trusts on 16,000 operations and start to work out whether they can start developing useful information to allow one surgeon to compare himself or herself against another and one department against another. They went on, and by 2012, they had analysed 55,000 operations from 406 surgeons in 12 trusts. The vast majority, not surprisingly, were phaco, and at that time, they had a 1.92% PC rupture rate, which was, again, not surprisingly, highest for junior and low volume surgeons. And they used the additional data they got from the patient's electronic patient records to start to develop a concept of low risk and high risk categories. And they also demonstrated, again, perhaps not surprisingly, that PC rupture was the only modifiable risk factor for subsequent visual loss. And these days, the National Ophthalmology Database is, I would like to say, a well-oiled machine, but I'm trying to make it as well-oiled as we can within the financial constraints we face. But essentially, it is quite a complex system based on obtaining data from existing electronic patient records in the vast majority of cases, passing the data anonymously onto the analysis system, developing the results, and eventually passing them on to the people that need to know. And the last analysis based on 2018-19 data analysed from that year, 241,000 cataract operations. And you can go online now as a surgeon, provided you've done over 50 cases, you can get your own assessment. So one of the key metrics is PC rupture rate, and the overall rate that year was 1.1%, and this surgeon had no PC rupture. The overall rate of visual loss was 0.9%, which I think was a loss of 3 lines. And again, this surgeon had none, and I'm pleased to say that was me. But I would also say, I'm not so pleased to say that I only did 88 operations that year. And then by hospital, this is my unit where we, again, compared to national standards, can say with some degree of confidence that we did we did well in our surgery. Now, you could argue that simply by publishing data, we're not really completing the audit cycle because we're not implementing change. The only implementable change that we do at the moment is identifying people who are 3 standard deviations from the mean, and there are actually very few individuals or departments in that category. But since 2010, there has been a 40% reduction in the PC rupture rate from 1.91 to 1.14. And I think this is a combination of some surgeons looking at their data and saying, actually, I'm not enjoying this, I'm not particularly good at this, I will leave. But also, there may well be some centres like this one where there were systemic problems. I think their microscope was fixed to the ceiling of a building that tended to shake. And when they finally showed this figure to their manager enough times, they implemented change, and the next year their complication rate had fallen considerably. As well as the reduction in PC rupture rate was a significant reduction in the number of patients suffering visual loss as a result of our surgery. So I mentioned risk stratification. We now have a model which gives us a likelihood of whether somebody is going to have a complication of PC rupture. And on the left, this is a person who's a very straightforward cataract. You've got a fundal view, the patient's able to lie flat, and essentially this person has probably got, with consultant operating, a PC rupture risk of 0.75%. By contrast, even though a consultant surgeon is doing it, on the right-hand side, we've got an elderly patient who's not able to lie flat. There's no fundal view. They've had a previous trabeculectomy. And now the risk of this person having a PC rupture during the surgery is 30%. So we can start using this big data to inform who should operate. And in fact, NICE guidelines on cataract surgery said we should consider using a stratification algorithm to decide who should have the surgery, at what level the surgeon should be to perform that surgery. And there's also the additional use of the data potentially. This graph shows the number of operations versus the adjusted PC rupture rate. And it's clear to me there is a rapid decrease in your risk of having a PC rupture the more operations you do. And perhaps it's time, and we are working on this at the college, to start saying this data suggests that maybe you should do at least 200 to 250 cases a year in order to be competent at the operation. And this in turn allows you to contemplate workforce planning. How many surgeons do we need to deliver the number of operations we need? And it also has important implications on how we train our juniors. So I'll stop there and move on to guidelines. And as has already been mentioned, the National Health Service was set up in July in 1948 with the aim that it would meet the needs of everyone, that it would be free at the point of delivery, and that it be based on clinical need, not ability to pay. And I think it's a brilliant innovation that Britain should be proud of. However, it has not been without its problems over many years. And in 1997, it was recognised that there was an inequality in access and quality of care across the United Kingdom. And as part of its attempts to change this, they set up an organisation called the National Institute for Clinical Excellence to give a strong lead on both clinical effectiveness and, very importantly, clinical cost effectiveness. And initially it got criticised as being a rationing tool for the government, but actually I think it's become an incredibly well-organised machine to provide evidence-based recommendations. It is directed primarily at England and Wales, but its recommendations are actually almost universal, they're applicable. It's based on the best evidence of what works, developed by independent and unbiased committees of experts and lay representatives. And the recommendations set out the care and services that are suitable for most people with that specific condition. They reckon that roughly a recommendation made by NICE should address at least 85% of the people with that condition. Now, one of their remits is how to compare the value of, say, a liver transplant from that of having a cataract operation. And it is very difficult to do that. But what they've done is come up with this concept of quality adjusted life year. And basically, a quality adjusted life year of 1 year is equal to 1 year in perfect health. And the way you calculate QALYs is by estimating the years of life remaining for a patient and weighting each year with a quality of life score from 0 to 1. I'll give you an example in a second. And essentially, NICE reckons that a QALY of 1 year is worth £20,000. So here's an example. This is a person who has a chronic condition, expected to live 5 years, but the condition is reducing his quality of life to half that of somebody in full health. So he has 2.5 QALYs. A new treatment comes along that doesn't increase his life expectancy, but does improve his quality of life to 3/4 of that of somebody in full health. So he's now potentially a treatment benefit of 1.25 QALYs, and NICE would now consider paying for that new treatment if it costs less than £25,000, because that's 20,000 times that 1.25. When they develop guidelines, and it is important to develop guidelines properly, you have to have a topic. What is it? In this case, it would be cataracts, for example. The scope, is it all cataracts or just adult cataracts? Is it in the primary setting or in the hospital setting? And then most importantly, you've got to define the questions. Guidelines are not textbooks, they are specific questions. What is the best way of doing this? How should we do that? Once those questions are defined, the stakeholders are invited to comment on the questions. Then you go away and actually do the literature search against those questions, do the analysis, draft recommendations, and then make a further consultation before it's finally published. And the average time is around about 2.5 to 3 years, and the average cost is at least £250,000. And this is why having NICE do this means that you get quality recommendations and a quality guideline. So I was directly involved as chair of the cataract guideline. It made 55 recommendations using terms like offer, consider, and you must. Offer means you really should do this. Consider means there is limited evidence that it might be of use, but on balance, that's what you probably should do. And we very rarely put you must unless there's a legal obligation to do so. It also made 17 research recommendations. And of all the recommendations, I'm particularly proud of this one. Recommendation 7, do not restrict access to cataract surgery on the basis of visual acuity. And at the time that we were doing this, there was a significant postcode lottery. Some local areas saying you had to have 618, 624, you can have one eye done, you can have 2 eyes done. There was such a variation that, in fact, the Minister of Health said we had to expedite this in order to get rid of that postcode lottery, as it was called. And basically, that recommendation was based on a very detailed economic analysis modelling the cost of first eye and second eye, immediate surgery, delayed surgery, and no surgery. And essentially what they found was, in essence, if you've got a cataract in either eye, if your quality of life is being restricted, there is no justification, financial justification, not to have it done, because it is always cheaper in the long run for the NHS to allow you to have your operation when you want it, at your level of quality of vision. In fact, so good is it, you could justify first eye surgery on a 90-year-old with 6/4 vision in both eyes. That's how cost-effective cataract surgery is. More recently, we've been working on an update to the glaucoma guideline, and I just draw your attention to what may have a big impact around the world, which is basically NICE now saying offer SLT surgery as a first-line treatment for both ocular hypertension and newly diagnosed chronic open-angle glaucoma. Finally, I'm going to change tack and talk about some epidemiology aspects that have been a learning curve for me. And I'm just going to illustrate this with the management of optic neuritis and how it changes across the world. So in the UK, most people with optic neuritis as adults do not require any investigation or treatment. And the justification for that statement comes from the optic neuritis treatment trial based in the States. And if you remember, they randomized patients to intravenous, then oral steroids and placebo. And their inclusion criteria basically was saying, if you thought somebody's got optic neuritis, they were in the trial. They did exclude people who had a systemic condition other than multiple sclerosis that might cause optic neuritis, but essentially it was, if you think somebody's got optic neuritis, they can be included. And what the summary of their finding was that you did not need to investigate them to establish the fact that they had optic neuritis or caused the optic neuritis, but you may want to do an MRI scan for assessment of their multiple sclerosis risk. It also found that you did not need to treat their optic neuritis, but you may wish to give them methylprednisolone to delay the onset of the multiple sclerosis. So in the United Kingdom, most clinicians have this concept of typical optic neuritis, where a patient between 60 and 45 with unilateral gradually progressive visual loss over a few days that has pain on eye movement and a relative afferent pupil defect and otherwise well, does not need any investigation to establish the cause, should be monitored up with a provisional diagnosis until they start to recover spontaneously, at which point the diagnosis is confirmed. And we have the vast majority of the typical, but we recognize as an atypical group where they need to be urgently investigated and urgently treated to improve their prognosis. And we recognize that there are other causes of optic neuritis, including neuromyelitis optica and anti-MOG, sarcoid, etc. And those patients where we think they're atypical, they get a battery of investigations, including anti-aquaporin 4 and anti-MOG these days. And they get a trial of treatment. And if they respond well, they will be on longer term treatment with oral steroids. And if they don't respond well, but they are thought to have an inflammatory optic neuropathy, they will have plasma exchange. And then they will move on to disease-specific long-term treatment. Now, the reason we get away with this in the United Kingdom is very simple. It's the contrasting the prevalence of diseases. And multiple sclerosis, the underlying cause of vast majority of typical optic neuritis in the United Kingdom, in the United States, is related to multiple sclerosis, where the population prevalence is over 100,000, 100 per 100,000. By contrast, in Tropicus, in India, in the Far East, this is considerably less. In contrast to MS, NMO prevalence is roughly somewhere around 1 to 4 per 100,000, and the geographical variation is a lot less. And what that means is, in Italy, probably similar in the United Kingdom, the chances of you having NMO as the underlying cause of your optic neuritis is only about 1.5%. It rises to at least 9% in India, and in East Asia up to nearly 50%. And therefore, the actual lesson we should be giving is the management of optic neuritis should be guided by the pre-test probability of the underlying condition being present. So in the United Kingdom, the high likelihood of MS-related demyelination as a cause means you're likely to have around about 90% as typical, probably another 9%, something I'm just estimating, who will have an atypical presentation of typical optic neuritis, perhaps they didn't have pain on eye movement, and then the rest will be other optic neuritis. But in other areas of the world, the prevalence of MS is much less, and therefore I would say in those areas of the world, all cases require urgent investigation and trial treatment. And for me, one of the things that I need to bear in mind in future is that textbooks should take more notice of regional variations in disease prevalence in order to make sure we're teaching appropriately for the population, the doctors that we're teaching. Now, I'm going to stop share and hope